that everything I've said during this webinar and this recording is my own opinion. I'm not representing either the California Department of Public Health or CDC, and I just want to make that real clear, and I don't have any other industrial disclosures to make. Thank you.
Good morning, everybody, and welcome to the fourth event of the Perspectives to Change Our World lecture series, which is hosted by the Academy X Club. Every month, we hope to bring world-class leaders to come to Campolindo, share their journey and story and perspective. With the introduction of the coronavirus, however, we couldn't actually go to Campo, so we're instead resorting to this online webinar where we still hope to continue spreading our message. The video I just played shows the beginning of the club's formation a few years ago, where I founded the Academy X Club in order to bring relevance to what we learn in school every day. I asked myself, kind of, why do we need to know these math formulas, and will I ever use this theory? And this club's mission is to answer these questions through hands-on projects and experiences that we do every year and we hope to continue doing. We actually use the information we learn in school to create tangible, impactful projects that could potentially change the world. And this year, we want to look outwards. Outwards to leaders who are changing the world themselves. Through this lecture series, we hope to gain their unique perspectives to one day change the world ourselves. This month, I'm honored to introduce this month's speaker, Dr. Joan Chow, an epidemiologist specializing in infectious diseases at the California State Department of Public Health. Dr. Chow received her Bachelor's of Arts from Yale College in Engineering and Applied Sciences, and her Master's of Public Health and Doctor of Public Health degree from the University of California, Los Angeles. She completed her postdoctoral fellowship with the University of California, San Francisco in the Department of Laboratory Medicine. Her areas of interest have been in the evaluation of new chlamydia diagnostic techniques, development of innovative surveillance systems, chlamydia and gonorrhea prevalence monitoring in family planning populations, development of screening guidelines, and evaluation of quality improvement interventions, amongst many other things. And in today's webinar, she will talk about epidemiology, discuss a brief history of infectious diseases, share some insights from her work in STD infection management, and share some information about COVID-19 and the coronavirus, kind of what is being done, what we can do as high school students, and kind of what the future looks like for this pandemic. So with that being said, I'd like to welcome Dr. Chow to begin our presentation.
Great, thank you so much, Armaan. And I guess we'll start with the first slide. All right, terrific. Thank you so much again, and let's go to the next slide. I like to start with this slide. This is a cartoon. It's a very old cartoon from the New Yorker by William Hamilton. And if you can see the caption to this scene, which is at a party with folks getting together, and the caption reads, "And it was so typically brilliant of you to have invited an epidemiologist." And I want everyone to notice when this was published. It was November 26, 2001. And it happened to have been published not that long after 9/11. And I think most of you actually were born probably after 9/11. But your parents probably remember that very, very concerning time of crisis. Shortly after 9/11, there was an outbreak of anthrax, and a very, very rare infection. And there were a lot of concerns about where the samples of anthrax that were appearing in mailboxes and envelopes that were being distributed to people in Congress. And so all of a sudden, a crisis like 9/11 and anthrax really spurred a lot of attention on epidemiologists, because they were called in to try to figure out what was the source of the anthrax and why were people being affected. And so this is kind of my introduction, I think, to telling people about what epidemiology is all about. So let's go to the next slide. This is a slide that shows two books that I think are really, really helpful for understanding and explaining to people what epidemiology is all about. Investigating outbreaks and epidemics is essentially telling a story to people about how, where, and to whom disease begins and to whom it spreads. It's kind of a detective story, and that happens to be one of my favorite book genres from when I was growing up. Some of the best stories have been written by Bertrand Ruchet, who published the first one way back in 1943 in the New Yorker. And the story was called 11 Blue Men. So the way it starts is basically a man collapsed in a Manhattan street and is taken to a doctor. He has abdominal cramping, retching, confusion, and an alarming bluish hue to his skin. The doctor is understandably confused and at first diagnoses carbon monoxide poisoning, which is known to cause cyanosis, which is this blue color to one's body as a result of not having enough oxygen. So the hospital prepares for a mass poisoning due to a gas leak or other possible causes. And they were right to do so because another 10 men turn up at the hospital with the same symptoms, and therefore begins the story about how these epidemiologists, or medical detectives is the term that was popularly known for these investigators, that led to the development of many stories by Ruchet about how local outbreaks, were identified and then investigated. So if you're interested in more of those types of stories, I would really highly recommend these two books. Next slide, please. Well, the 11 Blue Men is just an example of a small localized outbreak that's associated with inadvertent poisoning, as it turned out. But the history of medicine is full of much larger outbreaks which have impacted populations, both as epidemics within countries and then pandemics globally. This is a nice graphic that compares the magnitude of probably the most famous fatal pandemic cases that have occurred globally. And you can see the sizes of these different circles depicting different infections differs based on the magnitude of the number of fatal cases that were estimated associated with those infections. So starts with bubonic plague or the Black Death in the Middle Ages to more recent ones in the 20th century, such as measles, smallpox, and of course, the 1918 Spanish influenza. But there's many other pandemics, including most recently HIV/AIDS, which I think most epidemiologists of my generation have been most familiar with and have essentially learned control strategies in the last 25 to 30 years. But this is a really nice kind of summary of all the different kinds of pandemics and how much impact these pandemics have had globally. Next slide, please. So I want to start always with some basic definitions because people, when they hear that you are an epidemiologist, they get kind of confused and they think, well, it sounds like you're studying the epidermis. But as soon as you say, no, it's really about epidemics, small and large. So where does that word come from? And I always like etymology. So the word epidemiology comes from the Greek words epi, meaning on or upon, and then demos, which means people, and then logos, which many people know about, meaning study of. And so in other words, the word epidemiology has its roots in the study of what befalls or happens to a population. When you think about, in medicine, the patient is the person in front of you. Well, in epidemiology, the patient really is the community. So going to the next level, epidemiology is, how do you do it? It's the study of the distribution and determinants of health-related states or events in specified populations. And then you take that information and you apply it or translate it to actually controlling the occurrence of those health problems. Another really important aspect about epidemiology as a result of that approach is that it's really data-driven, and it relies on a systematic and hopefully unbiased approach to the collection, analysis, and interpretation of data. And as a result, it's a very quantitative discipline that relies on a working knowledge of probability, statistics, and sound research methods. And the reason why it's based on probability and statistics is because there's an underlying assumption that disease is not random. So you need to have some methodology to kind of test that hypothesis that disease occurring to particular people is not random. The other aspect about epidemiology is that it's a holistic method of causal reasoning based on developing and testing hypotheses grounded in a much broader set of scientific fields such as biology, behavioral sciences, physics, and ergonomics to help explain why disease is occurring at a level that's above what is expected. And I'm so glad that to have seen the video that that Armaan presented, talking about how you as high school students, given the kind of broad education that you have, are really trying to integrate those methods into solving a particular problem, like how to produce a much more efficient way of growing plants, for instance. Next slide. So here's another graphic that really basically shows you what I was just trying to explain about how broad epidemiology is, that it's multifaceted, multidisciplinary. And this shows you all the different kinds of factors that are involved in doing rigorous epidemiology based on the different kinds of data that are available, both about the exposures, the risk factors, the behaviors, as well as the types of diseases and disease outcomes that we are trying to prevent. So you can see, for instance, that it's not just infectious diseases, but it's also chronic diseases, cardiac, lung, and breast cancer, for instance. It's a study also of looking at different exposures, not just bacteria and viruses, but also looking at food, for instance, norovirus outbreaks. How about environmental exposures? So, the kinds of outcomes that are associated with that in the air that we breathe that might happen to expose us to Legionnaires, for instance. There are different other modes of transmissions that involve lifestyles and behaviors. For instance, our use of drugs, for instance, and also in the area that I'm most interested is in sexual networks. Okay, next slide. So Armaan asked me to briefly talk about, how my career in epidemiology started. And so here's one path to epidemiology, but there are many, many paths. So I grew up in New York, and I went to high school there way back in the 60s and 80s. I'm gonna close. And then that followed by my going to Yale and majoring in engineering and applied science. And already from college, I was very interested in the biomedical sciences, but I think through exposure to biomedical engineers who, again, were searching for solutions to how to use engineering principles, much like what Armaan just showed you, how to apply them to solutions in issues, for instance, how to develop a synthetic material that could substitute, say, for a heart valve or to bones. So that was one exposure that I had that was really, really kind of fun. But one of my many jobs when I was in college was also working in a women's health clinic. And through that exposure, I was able to understand a little bit more, particularly in the 70s, when there was a lot of activism around access to women's reproductive health. There was a lot of concern about how to increase that type of care to more women that really had no access or very limited access. So I started thinking about sort of broader types of infections and disease outcomes occurring to women that were definitely preventable. And so I decided to then pursue a pathway through public health. And you can see that it took a while. Most of my 80s was involved in attending graduate school in public health at UCLA. And there again, continue to hone in on some of these disease outcomes that were of particular interest to women. And so there was a department at that time, it's now been incorporated into another one called Population, Family, and International Health. And again, it was this kind of very holistic type of education, which involved looking at a wide range of issues around the pathophysiology of women's health diseases, as well as epidemiology, demography, and social sciences, trying to, again, develop a kind of a set of skills that would allow you to use methodology to answer questions about how to prevent certain kinds of adverse outcomes for women. And so in the end, as a result of listening to a lecture by a visiting investigator from the CDC about a concerning rise in the increase of pelvic inflammatory disease and ectopic pregnancy. And those are infections that and outcomes that basically are associated with infertility in women. Why at that time was ectopic tubal pregnancy occurring? And so once again, there was this question that hadn't been really answered. It was just starting to be answered in Europe by analysis of cohorts of women who were having these problems that were associated with sexually transmitted diseases. And there was one in particular, and you'll see in the next slide, how I just happened to be at the beginning of some of the development of tools that allowed us to answer that question. And so the dissertation, as a result of the collaborations that I developed with the Chlamydia laboratory at UCSF, allowed me to look at why it might be that women with tubal pregnancies were potentially more at risk for that as a result of past exposure to one infection called chlamydia. And we did that using serology, and I'll come back to that. It's something that's relevant to what we're trying to understand around COVID-19. In any case, I continue to work on that with the laboratory, and I had the great privilege of working mostly with microbiologists at that time who were developing a lot of the techniques, molecular techniques that are associated with the diagnosis of chlamydia. And then I switched over to the California State Department of Public Health, the Division of Communicable Disease Control, because they were looking for more epidemiologists who had that kind of laboratory background. So again, trying to really make the case that it's not just about the analysis, but really developing an academic context, I think, for anyone who's going into this field, that it's very appealing for many reasons for people who have a diverse set of skills. So that's where I've been until 2019 when I retired. So next slide, please. That's one path. All right, so why focus on sexually transmitted diseases? Well, for one thing, there are still a lot of them, and the CDC has this nice infographic just trying to give people a better sense of this, in many cases, what has been called by the Institute of Medicine as a hidden epidemic. So the reportable bacterial STDs are chlamydia, gonorrhea, and syphilis, as you can see in the top of the graphic. And even though they all are transmitted sexually, not everybody's at risk for every single one of them. And there's this concept of networks, and just because you have chlamydia doesn't mean you always be at risk for gonorrhea and for syphilis. They actually have very distinct epidemiologic characteristics that set chlamydia cases apart from, say, gonorrhea and syphilis. And as a result, there are different public health control strategies for that reason. So that's one explanation for why STDs continue to be a major focus of public health departments in the United States and elsewhere in the world. One other aspect I just wanted to say about STDs is that here's just the absolute lowest limit for our understanding about the extent of STDs. In the case of chlamydia, this is just the tip of the iceberg. Most cases are asymptomatic. So it says 1.7 million cases. It's the most commonly reportable sexually transmitted disease, but actually the true number is probably much, much higher, and it's probably about 4 million. So it really gives you a sense of, there's prevalent infection that's being transmitted just of chlamydia. How do we deal with that? And so this is a question that I found really, really important, and so that's why my particular emphasis on it. So next slide, please. So again, when you think about how to approach a problem that is so widely prevalent like chlamydia, you have to sort of think, what are the key characteristics that we want to be collecting data on? So there's this, very, very simple person, place, and time orientation that we have. And so I'm just going to go through real quickly about what it is about chlamydia that can be characterized. What do we know? Well, first of all, as I said, it's the most common reportable disease, bacterial disease in the United States. And chlamydia is also known as a silent infection because most infected people are asymptomatic. So as you hear this, you can sort of start seeing commonalities with potentially with COVID. And then most importantly, that there is preventable outcomes that are pretty devastating to people. And while it doesn't cause death, as in case of HIV, for instance, if you're not actively looking for it and treating chlamydia infections, you can actually have some very, very tragic outcomes in terms of infertility, ectopic pregnancy, which actually does have fatality associated with it for the mother, as well as other outcomes that are chronically problems for women that have a major economic cost. So that's just a snapshot of why chlamydia is important. Let's go to the next slide. So what do we know about chlamydia? Well, it turns out in this particular depiction of the age profile, in other words, we're comparing the rates of chlamydia in terms of based on just cases alone, that is people who've been diagnosed and tested positive for chlamydia. And how does that look when you look at both males and females with respect to the rates by age? And these are 5-year age categories. This is a very typical kind of age pyramid. And it can look very, very different for other infections. But so if you just look to the right, you'll see that the highest rates, as shown in the bars, are among women and also men who are aged 15 to 19, so adolescents, and then young adults, 20 to 24, and then it rapidly drops after that. So you start thinking, okay, so there's a very distinct age risk that's associated with chlamydia. Let's look at the next slide. All right, what's going on in terms of time? Well, it looks like since 2000, the rates of chlamydia for both men and for women have been going up steadily. And there's just very, very little change. It's pretty consistent. There's some declines, but they're just very, very momentary. And this epi curve shows that it's just going up and up. So why is that? And the other reason, observation that people take away from the previous slide and this slide is, why is it that women happen to have higher rates than men? They're both going up. Well, it turns out that women tend to access care much, much more frequently. There's some real, rigorous guidelines, I think, for women, especially once they become sexually active, to see their obstetrician gynecologist, get a pap smear, get contraception, and so forth, pretty much have been almost on an annual basis. So men don't go in that frequently. They don't have the same kind of care guidelines. But nevertheless, given that this is a sexually transmitted disease, that women do get diagnosed, then partners get brought in, and so they also have been tested, and you see those rates going up as well. And then the next slide shows, where is it happening? The CDC does a very nice job of looking at county level as well as state and national level comparisons of chlamydia rates. And so basically in 2018, you can see your eye is just drawn to the difference by county, starting from the counties with the lowest rates. So the legend on the lower right shows you that the rates are low where it's pale yellow, and it just increases in intensity. And the darkest colors are where the rates are highest. And so you can see that the distribution of chlamydia pretty much is all over the United States, but in certain places, definitely in the Southeast and in urban areas. California, you can see, is pretty much in the dark blue, with very few exceptions, probably where there are very few people who are living. Alaska also has some very, very high rates, and some of the Hawaiian Islands as well. But this kind of geographic disparity, again, so why is that happening? And is it differences in screening, or is it differences in the distribution of younger people? These are all questions that come up as you're looking at data like this from different perspectives. All right, next.
And Ms. Chow, can you explain why is there so many, or why do you think there's so many, such a concentration of reported cases, and especially like California and like the southern states? What could lead to that possibly?
Well, one possible explanation could be that there is a lot of screening that's going on. I mean, I think that in some of these counties where there's a lot of healthcare and providers are doing a pretty good job of screening women, particularly women in those age groups, adolescents and young adults, and there's a lot of access to healthcare. Basically, there's it's characterized as the more you look for something that is asymptomatic by screening, the more you will find. So that's one possible reason, but it can't be all of that. And so you then start looking much more carefully at the men and the women who are in their communities, and what their risk behaviors might be, and it's possible that there is less access, for instance, to sexual health education in some of these counties. School policies around access to sexual health education varies quite a lot. And so again, you start thinking about what is the community context in terms of prevention. And so prevention starts all the way from knowing about condoms, about how to protect yourself with respect to acquiring infections, all the way to having access to healthcare. And in many of these counties, there may be very poor access to screening, chlamydia tests, and then treatment, and then control through retesting, as well as testing of partners. So there's access issues that may be determined by community characteristics above and beyond what's happening for a particular person who may be at risk. So those are possible explanations for variations by county. Good question.
Thank you. Let me change the slide.
Okay. So what does it take to control one infection, chlamydia? And so I put this line on just to give you a sense. This is a long timeline. 1907 is when Chlamydia trachomatis, which is the organism associated with sexually transmitted chlamydia. And so that's the beginning of the 20th century. And then it's not until way later, into the 40s, into the antibiotic era, that we actually have a treatment, which was at that time doxycycline. And then you go, a little bit further along. It's really, a long period of time before finally we have the one clear microbiological technique for actually isolating chlamydia. That's not until 1965. My mentor, Dr. Julie Schachter, was a graduate student at that time at Columbia. And so he worked with other investigators to help develop those culture techniques to actually isolate the organism. And then again, another long stretch of time, and back in 1980, all of a sudden there is evidence that azithromycin, another antibiotic, is found to be effective, and so that makes it a lot easier. It's just one dose that's given. So that's really important to have that treatment that is easy to administer, but it still was hard to diagnose chlamydia. And so you can see if you follow the red circles, all of a sudden there's this acceleration, particularly 1995, 2000. We actually are able to develop molecular assays, which are much, much easier, much more sensitive, much more accurate. And that's a really, really key aspect of a control strategy. And we're going to come back to that again for COVID. Very much easier to take a specimen such as urine. You don't have to have an examination. You can, pee in a cup and drop it off at a laboratory, or send it in the mail, actually, through to an online service that does testing. And all of a sudden, you can start seeing that as you get more tests being made available amongst communities, you can also see that there is a corresponding rise in the number of infections that are going to be identified and detected and reported. There are also guidelines that are, you can see that impact surveillance that are in the blue dots. And that, again, is another really, really important aspect of control, is that you have to know how much disease is out there. So by making something reportable, and this is what CDC does, and also state and local health departments, they want to be able to count how many cases, because you have to know how much is out there, how much you're actually really dealing with, and how much more potentially, particularly with an infection that's mostly asymptomatic, how much more screening you're going to have to do. And so these are all the components that it takes for controlling just this one sexually transmitted infection. All right, next slide. So now I'm going to jump over to applying what we know about chlamydia control that is relevant to COVID-19 control. So what I've done here is on the left, really try to kind of tick off the boxes for important characteristics about chlamydia. We've known about this infection for over 100 years. And so we've had a lot of time to learn about this organism, and then contrast it with a novel organism like coronavirus 19 that we don't know very, very much about. But let's see how far we can get, in terms of what we can apply from chlamydia control to what we can apply for COVID-19 control. The first aspect, which I've talked about, is that there's a very high percentage of chlamydia infections that are not associated with symptoms. In fact, probably 90% of women and men who have chlamydia don't even know it. So that's why screening, the next thing, is very, very important. And in fact, we know from our modeling that we need to have a very, very high proportion of people who are sexually active that need to be screened and tested in order to identify all those infections. Luckily, we have a very sensitive RNA or DNA test that can be done pretty easily. And it's a pretty fast test in terms of getting a result back. That's probably within a couple of days. There are some tests that can be done in 90 minutes and so forth. Let me just stop there in terms of what is relevant about COVID-19. Well, if you look on the right, yeah, similar estimates in terms of the percent of COVID-19 infections that are asymptomatic. And this is why there's a lot of concern about getting screening going. We don't know exactly, except from very small community level surveys of people in San Mateo, for instance, that were screened to see what proportion of those people in the community actually were positive but didn't have symptoms. And we have seen from that, and also from other screening surveys elsewhere in other states, that this percent that it's asymptomatic is very, very high. So screening and testing, not just the people who are symptomatic with the cough and issues breathing, but asymptomatic contacts, for instance, is really important to be screened. And so again, there's a very important similarity. We have a high percentage of people potentially with COVID-19 that need to be screened and tested, and we're not there yet. And I think that's one of the issues around control, effective control for COVID. It's not knowing how many people actually are positive. We do have a sensitive reverse transcriptase polymerase chain reaction test that have been developed first by CDC, as you've heard, as well as from other countries that have been dealing with COVID-19 originally. But again, there's issues with how broadly local public health labs and commercial labs have been able to actually do that testing. But there is a test that does exist. How far it's going to be distributed and accessed by people is a critical issue. And presumably there is a fast test, what we call a point of care test that I believe Abbott has created, and a couple of other test companies have developed that are kind of similar to other sort of fast tests that they have developed for influenza, for instance. So those are the key issues there's that we can kind of apply in terms of principles of detection from chlamydia to COVID. It's very similar. So going back to chlamydia, do we have an effective treatment? Absolutely. We have a one-time, one drug, azithromycin, that has been tested many times. There's a wealth of information about how effective it is. Well, is that true for COVID-19? Well, that's a big question. And that's why there's so much effort being placed into actually designing and implementing randomized control trials in order to determine whether existing treatments actually can be effective, not just for severe cases, but also for milder cases of COVID, so as to prevent development of some major complications as well as death. So we are really behind right now, but again, a lot of effort is being placed into having an effective treatment. Going back to chlamydia, what do we know about the spread of chlamydia? Well, there's definitely networks of chlamydia that are important for spreading, for transmitting the infection. So what's been the public health strategy? Well, essentially, there's so much chlamydia that it's really up to the provider to help find those sexual partners that are in that network, test them and treat them, and also make available condoms so that people who potentially are at risk for either transmitting or acquiring actually use condoms and then prevent the transmission. So between those two types of public health strategies, we potentially have the opportunity to control transmission and hopefully bend that curve for chlamydia. Well, turning back to COVID, again, we know that there's very easy network spread. And in the beginning, when COVID-19 was first identified in China and then in Italy and other countries before the United States, the primary way of controlling network spread was to really go find the contacts of the cases that were positive, that tested positive on the molecular assay, make sure that their contacts were also tested, and then quarantine was very strictly used in order to contain the network spread beyond those cases. And so that has been a real challenge, I think. That was the so-called containment phase for the cases as they were coming. But as it became evident that there was much more transmission among asymptomatic people, then that's when we had to start thinking about social distancing, physical distancing as another way of really limiting the spread, the whole limitation on physical gatherings and so forth, closing of schools. And so it's a similar approach in terms of trying to contain spread in the community, but much more stringent impact on the community. And then lastly, what do we know about immunity? Well, for chlamydia, immunity, there is some immunity to chlamydia, but what we found, especially as we've been trying to develop a vaccine, is that the immunity, the immune response on the part of the person who's been infected is really pretty weak. And as a result, being infected again with chlamydia, having repeat infection is really, really pretty common. And so that's what made it really, really difficult, I think, to control the ongoing transmission of chlamydia. What's the case with COVID? We really don't know. And again, this is where serologic tests, that is testing the blood of cases, and is really important to look at the level of antibodies that develop as a result of having been infected with COVID-19, as well as looking at people who are asymptomatic and yet infected, and looking at that sort of spectrum of immune response to figure out whether or not there is sufficient immunity that might prevent someone from being infected again. And can some of that information be used to help to define who might be then able to work amongst, to augment, I think, our public health response and not be at risk for another infection. There's a lot of work right now around serologic tests looking at antibodies for COVID, as opposed to, say, using the PCR molecular assays to see if you actually have the agent at the time that you're being tested. So those two types of tests are really, really important for control. Okay, so I'm going to go next to, well, do we know that control measures work, such as the ones that I just mentioned for chlamydia and for COVID? I'm going to start with gonorrhea, because as you saw with that earlier chart, we haven't really bent the curve. That's been our technique, our term for trying to change the trajectory of sexually transmitted diseases. And for gonorrhea, which is another bacterial infection that's sexually transmitted, we actually have had a much, much longer kind of history with trying to control gonorrhea. And so this is a chart that was published by Dr. Peterman at the CDC, looking at the history starting all the way back, from 1963 on to 2015 in terms of the rates of gonorrhea, and what are the possible causes that are associated with changes with bending that curve during this very long period. So we started in 1963, and you can see that the rates of gonorrhea per 100,000 population were just going up and up and up and up. And I think it's been pretty much accepted that during that same time, from a cultural perspective, that there were some real changes culturally around attitudes towards sex. And so you can see the gonorrhea rates were also going up as a result. There's access to contraception. The pill was discovered and produced in the early 60s. And so there's this the concurrent rise all the way up to 1975, and that's when it was at the peak. And the CDC decided we were really going to use containment as the strategy. And so there was a very, very major investment in disease investigators. And these are the people who constitute the public health workforce, and still, but to a much lesser extent, who basically go out, find the cases, test them, treat them, and also find their contacts. And so the United States really, really put a lot of money and really supported local public health programs. And you can see that the curve started to bend. And particularly around 1981, when the first cases of AIDS and HIV started to be identified. And so after that, you can imagine that there was a major, major impact on sexual transmission of all STDs at that point. Same thing with syphilis. And so there's a major, major drop and greater acceptance, I think, of condoms, for instance, as part of HIV control programs begin to really, really make a difference in terms of the effect on gonorrhea. And so it's been pretty steady, and the rates fell for gonorrhea back down to, well, before the same rates from before 1963. So that's one kind of piece of evidence potentially that you can look at for the effective control measures. Well, let's look at what's going on with COVID-19. So again, our objective over the last couple of months is to try and flatten the COVID-19 curve all over the United States, particularly in Seattle, San Francisco, and in New York, as we all know. And this, I think, is a really complicated slide, but I'm hoping it's going to be a really nice opportunity to look at all the data that we have about COVID-19 and the impact of different kinds of interventions. So let's start with the x-axis, which shows the days starting from February to April of this year. And the public health interventions are noted by arrows as they occurred by date. So on the left, you see the first one, which was the San Francisco state of emergency declaration. And this was followed by further interventions at the state and county level, state and national level, including limits on mass gatherings, school closures, and stay-at-home orders. So you see those occurring over time. So then let's look at the possible other things going on. Let's look at the total number of COVID-19 cases over time in San Francisco, which is in this smooth line, and it's measured as the number of cases on the right axis. The total cases rise from zero in early March to a total of about 1,600 by April. So you can see that's the total number. It's not the daily number, it's the total number. And that's something that we've all been watching to understand the burden of infection in San Francisco as opposed to, say, New York or Seattle or New Orleans. So how do we measure the potential flattening of the cases during this period of time? And so one way is to actually monitor the average 3-day percentage change in the case count. So that's shown by the dotted line curve. So if the curve is flattening, then you would expect this percentage to decline over time. And that's pretty much what you see happening by mid-March, with a couple of little increases likely due to increased testing and reporting. But otherwise, that line is essentially going down. So that's a positive in terms of flattening.
And,
lastly,
Ms. Chow, why a 3-day average? Is there a reason for that? Why not 5-day? Why not 1 day? Is there a particular reason for 3-day?
You know, it's to really try to erase some of the volatility, the random scatter of cases from one day to the next. So you're right, the choice of the time interval that you're trying to measure percent change it's kind of like the three bears, right? Not too short and not too long, because if it's too short, then it's gonna be erratic, essentially. If it's too long, then you're gonna miss any long-term changes. So what you want to do is to try to be as specific as possible. So 3-day is what the CDC decided was a reasonable period of time, given that you're measuring in days. Now, if you're measuring in years, that would be a different kind of choice of the percent change that the time period would be based on. So again, you know, it's kind of a balance, I think, between too short versus too long.
Right.
It's a good question. And again, this is the kind of decision making that epidemiologists have to make in terms of trying to figure out what's the right measure, what's a really meaningful measure for summarizing change in something like disease rates. And so lastly, how do you measure compliance with a control measure such as stay-at-home orders? Well, one way is to monitor the percent staying at home. And this was kind of interesting. This was based on, the data were based on cell phone GPS for a sample of San Francisco residents, about 160,000 people in San Francisco. And so what you want to do is to follow the dashed line, and this time you're going to look at the left axis, which shows the percent of cell phone users who left their home. And you can see that percentage that left their home at the beginning of February was about 80%, and then it fell to about 50% by April. So indicating some compliance at least based on cell phone GPS data. And this is a really very new, innovative way to look at impact of a public health strategy. And I've got lots more information about that. This was a chart that was reported by the CDC and also the San Francisco Chronicle. You can also look at the San Francisco Chronicle, I think as of yesterday, which shows at least what's going on in terms of cases, the number of cases over time, and whether flattening is actually happening by county. And so I think it's really helpful to look at what's going on in San Francisco versus San Mateo, which is where the first cases were identified, as opposed to LA versus the Central Valley. And so these are data that you can actually look at and compare what's going on in terms of impact and flattening. So I know that was a very complicated slide, but let's look at the next one, which I think a picture tells 1,000 words. And again, this is the same data, but this time it's shown in terms of a map. And on the left, essentially, we're showing the compliance with stay at home based on that cell phone data. And you can see that there's some real, bright spots that are happening, up in the upper right corner of San Francisco. And that was as of March 11th. Well, by April 1, there was a major change in the percent of residences that were leaving home. And so you can see it's a very, very much smaller concentrated group. So again, it's a very kind of crude way of looking at compliance with staying at home. So that again was reported in the Chronicle. All right, so let's go to the next slide, which gets at this issue of how can we do better in terms, what have we learned so far based on the way the public health response to COVID has actually rolled out. And so there are a couple of take-home points I think that are important for all of us to really, really embrace in order to really make an impact in the coming months and years as well. And first of all, there's multidisciplinary collaboration is absolutely essential. I think we have seen how fragmented our public health system is, even within public health, but also in terms of public health relationships with laboratories, with academic partners, and so forth. So the first thing is that we really, really need to enhance our ability to translate research from our academic partners to a commercial pipeline, for instance, so that we can actually leverage the genomic information that we're getting from sequences about COVID strains, so that we can develop more sensitive and hopefully faster tests, treatments, and vaccines. That kind of information needs to really move much more quickly and into development. And then, of course, clinical trial partnerships with public, private, and academic partners is really, really critical. Right now, we have a lot of information kind of floating around in the news about possible impact, for instance, for certain treatments, but they're really, really not very robust as yet. And so, in order to be efficient with gathering that information in a meaningful way and sharing it, so that we can really have some real evidence to proceed with treatments, for instance, that's going to be really important. And that kind of fragmentation has also been very, very evident. Another aspect of collaboration that's really, really going to be critical is to include the use of big data and data science. And I've just given you an example of how something like cell phone information, GPS information can be incorporated into understanding, first of all, where disease is and whether there's impact in terms of whether or not people are complying with a public health intervention. There's absolutely a real need for real-time disease monitoring. Surveillance has really changed a lot over my career. It's used to be paper-based. and there was real time lags, but right now we actually have other ways, I think, of monitoring what's going on with individuals. And you just think about, your Apple Watch and the ability to have apps that monitor biometrics. It's important to have disease monitoring based on clinics and hospitals transmitting information about, say, admissions for COVID-related infections to public health surveillance systems. That has been a major issue that we've been working with ever since 9/11, and trying to address potential bioterrorist events. And it's been slow, but I think it really has to be embraced much more widely. And other sources of data that come from social media and search engines, Google, Twitter, I think are really important for understanding the scope of disease in general, but particularly in this case for understanding the extent of COVID-19 infection in the community. And then there's a whole area of mathematical modeling, I think, that has been really much more appreciated. I think as people try to understand, how much are we missing potentially, and how much impact could we have in terms of public health strategies for COVID-19. Mathematical models, such as the ones that were shared by the Imperial College in London, that really had an impact, I think, on US policy with regard to social distancing and really trying to get testing ramped up. I mean, those are really important from a policy standpoint to say, we don't have all the data, but here are all the scenarios that people should consider in terms of what next to do for an impactful public health strategy. So mathematical modeling is something that's been really grown as an academic discipline, and it's exciting to see that people are really paying attention to how it's being used, some of the limitations, especially in the face of an agent that we really don't have a whole lot of information about. And then the third really big aspect of collaboration has to really help us understand the so-called social determinants of health. We know from the data that we have on COVID-19 cases that there are some major differences in the impact of COVID based on income, poverty, environment. And so this is really critical, I think, for enabling public health to be a means towards social justice. Is to enable access to all of the interventions, whether it's testing, treatment, for people who don't have that kind of access. And I think there have been some very important observations in the last month or so about disparities by race, for instance. Certainly identifying those who are vulnerable to lack of healthcare, people who are now out of work and don't have access to healthcare. And so those social determinant factors of health have always been a part of public health strategies, and never more so than I think with COVID. And so the next big area, I think, in terms of how we can do better is to really enable local, state, and national public policy to follow the science. We need to really think about our investment in terms of basic science research, and importantly, how we are supporting or could do better in terms of supporting local public health departments, the infrastructure, whether it's surveillance, disease investigation folks, the workforce of public health, I think, is an investment that has really diminished in the last 20, 30 years. And so it's going to be really critical if we think that contact tracing for cases and treatment and quarantine are going to be really important for preventing COVID-19 from surging again come summer and fall. That investment in the public health infrastructure is really a critical piece of it. And of course, preparedness planning and really doing these simulation feedback loops is really critical. And we've had pandemic preparedness plans in place certainly since the early 2000s, ever since SARS, the first coronavirus agent, was identified. And I think we've really, really lagged in terms of supporting that and really implemented preparedness planning and kind of seeing where all the gaps are in terms of our response. So those are how we can do better. All right, next slide. So Armaan asked me to come up with a couple of possible next steps, I think, certainly for students to consider from given your skill set and your interest, I think, in public health and particularly in the age of COVID. This is one, now it's no longer the case, but there used to be a competition a few years ago called Young Epidemiology Scholars, and it was kind of like the, I guess, the larger national science talent competitions. But what was really nice about it was that it really, really, gave a forum for students, mostly high school students, to really think about innovative ways to solve public health problems using epidemiology. And it was wonderful that they also funded it. The prize money was really in the form of monetary prizes, and so I'm hoping that maybe we can do this again. It's another way. Next slide. Well, what else can you do? Well, it turns out that the CDC actually has a disease detective camp, and again, this is for high school students who are interested in spending a summer at CDC, learning from public health professionals to actually work through a lot of the methods. And so I've at the bottom of these, I put where you can actually learn more about that summer experience, as well as some of the courses that CDC has developed in order to walk you through some of these techniques. Next slide. And this is kind of fun. CDC has been really, really trying to listen to and understand how to teach, I think, in a way that's really engaging and fun. And so they actually have a way for people to practice solving an outbreak. And so there's a whole bunch of these scenarios that you can work through, and the link is on the bottom. So you can put yourself in a place of being a medical detective and do this using some very, very current kind of information from the CDC. All right, next. And I think is really, really important is that we need to learn from how we've managed other outbreaks, and so taking some time to read through older outbreaks is really, really helpful. And so I have again a link to these older outbreaks from all over the world, everything from AIDS to polio to guinea worm, for instance. Just some really inspiring stories. One of the best sources of history that I can recommend is the work that's being done by Professor Frank Snowden, who's written quite a lot. He's a historian at Yale, who's written a lot about these older epidemics, what worked, what didn't work. And he's actually been interviewed quite a lot during the last couple of months regarding COVID and what those older pandemics have to teach us about what we can do to prepare for future pandemics. So I put that there as well. And I think the next slide is just professional resources. Again, if you really want to peek a little bit more closely into some of the conversations that occur among epidemiologists, there's a publication called Epimonitor, and also the American Public Health Association actually has a lot going on in terms of the literature, not just for infectious diseases, but across the whole spectrum of conditions that epidemiologists deal with. All right, and I think the next slide, okay, this is my last professional resource slide. And it sounds really intimidating. The Centers for Disease Control and Prevention has a weekly publication called morbidity, mortality weekly report. It just sounds awful, but it can actually be quite fascinating because it goes through every single outbreak and monitoring of disease, infections, and chronic that you can imagine from all over the United States by state. And so they've been really, really on top of a lot of the information around COVID. That really complicated chart came from them just this week, and you can not only watch what's going on with COVID, but you can also look at all the other outbreaks. And at the bottom it's just a screenshot of the other outbreaks having to do with mushrooms, clover sprouts, pet store puppies, lung injury, raw milk. Again, just a really, really interesting window in the very, very wide spectrum of epidemiology work. Okay, I think, yes, here we are. So your questions, this is another fun cartoon from the New Yorker. I usually put this at the end because people's eyes are glazed by the time I get to this point in my lectures, but it says I'll pause for a moment so you can let this information sink in. All right, Armaan, go ahead.
All right, so that was fantastic. This was the last slide, the thank you slide. So I'm going to stop screen sharing now. Let's see. Give me one moment.
Ron, do you see the question answers? There's 5 questions.
I do, yeah. So I'm going to transition now. Thank you so much, Ms. Chow, for going through that. It was very informative and a bunch of great information there. And throughout this kind of talk, we've gotten a few questions through the Q&A section. And I'm going to ask you a few of those from the audience. And also, if anybody else watching has any questions, feel free to just click the Q&A box at the bottom and then type your questions, and I'll be answering them live. Or Ms. Chow will be answering them, actually. I'll be asking them. So this one's from Kimia. She asked, can you discuss the waves of the coronavirus? Many people, including myself, are confused about this concept.
I'm sorry, the first sentence about the wave?
Yeah, she said she's a little bit confused about the waves of coronavirus because she's heard that in the media and she's heard that a little bit. And she was wondering what that really refers to in waves.
All right, so really, really good question, because I think when you look at the graphs of COVID-19 cases, you do see, as expected, these increases, the first wave, so to speak, of reported COVID cases. We'll see from symptomatic people, people who've been hospitalized, the severe cases, and so forth. And so the hope is that with strategies, with applying strategies like social distancing, the face masks, closing schools down, and so forth, that you can actually flatten the curve. And that's what we're all hoping for. And we're hoping that the continued use of those public health strategies is going to then flatten that curve, allow healthcare facilities to really, really take care of the people who are hospitalized. And so eventually there is going to be a decrease in the number of new cases coming up. The concern about waves is that once we stop doing those social distancing, following those recommendations, more people come back out into the community. And unless we have ramped up our testing so we know exactly who's infected or not, unless we have done the testing to know who's infected or not, there is the potential for another wave. So in other words, you're going to see, just like you see in a wave, you see that another increase on the curve for the number of cases of COVID happening. And whether that happens in summer, in fall, or so, kind of depends on knowing a lot more about how many people are infected, whether there's any environmental impacts, for instance, warmer weather, is that going to make a difference? We don't know. But this is exactly what happened with the 1918 Spanish flu. There was a wave of people who are infected, and then there was a second one as a result that was much worse than the first wave, the first number of cases. And so hopefully that gives you an idea that as people are infected, maybe they have immunity, maybe not. It's really unclear. But we know that it does happen. And as with influenza, we know that there are seasonal waves, for instance. But in this case, it might be a lot shorter between waves. Hope that helps.
Yeah, and hopefully, Kimmy, that answered your question. Here's another question from Charlie Hill. In terms of transmission of COVID-19, I've seen that over 99% of cases being from an infected surface coming from contact with the face, as opposed to someone coughing on someone else, for example. Do you believe this is true? And knowing this, should it change how we try to prevent the spread? So kind of asking, he's seen a few things where interactions with the face, objects touching the face, are more likely to spread the virus than coughing. Is that true? And if so, or if not, how would you change our actions to try to prevent this spread?
Well, I think that there's a lot of evidence about, basically the closer a COVID-19 virus gets to where your body can enter the body, the more likely that you are going to be infected. So touching your face enables, anything that you've touched on a surface to actually get that into your mouth, your nose, your eyes that much more easily. In terms of the surfaces and in terms of the coughing, for instance, the coughing has to do with, someone actually coughing COVID-19 particles out into the air. And the idea is that if there is, less than, 6 feet of distance between your coughing and the next person, that there's potential for those droplets with COVID-19 particles to actually reach someone else within that, say, six foot distance. And so, I think the potential for surface contamination versus, it's those particles are going to sit on those surfaces. So if you're not washing your hands and wind up not only touching those surfaces and then touching your face, you just have this continuum of transmission. I can't tell you one is more effective than the other. I mean, in other words, if you have a contaminated surface, that has been coughed on, for instance, you want to clean that surface for sure.
Right.
That's what those wipes are for. But if you don't, and you touch that surface and then touch your face, you're increasing the likelihood that you are going to be infected. So that's why touching your face, don't touch your face recommendations are really important. Same thing with face masks. I mean, that, again, people who wear face masks but still futz around with their face masks and adjust it, pull it down, and that kind of thing kind of enables that touching of your face to happen even though you're having a face mask. So again, you have to be really, really careful about what you're touching, whether it's, but definitely don't touch your face.
Right. Awesome. And I've gotten a few questions here talking about your view and your perception of how long this might take from Paige and Isabel and a few others. So how long do you think the shelter in place will last? And when do you think places like schools or restaurants or grocery stores or things like that will open up even further? And maybe even what is the priority list that you see of kind of venues being opened up?
Yeah, this is a really big question mark, I think. This is something that the governor is struggling with, the president's struggling with. And as you probably have seen across the country, I mean, there's different levels of compliance with, say, shelter in place and closing of schools and so forth. I mean, at this point, most states have these orders in place. And the question is, when do you take your foot off the pedal kind of thing? And a lot of it is so dependent on how much testing is going to be happening in the next couple of months or so. What kind of tests and who's going to be getting those tests. And I think assuming, and again, that we have the kind of serologic tests that can tell us whether someone has developed the antibodies to COVID, whether those are developed and then distributed broadly. I think that the priority, if we are going to start allowing people to go back to school or to open up restaurants and so forth, is really going to depend on how well we test everybody. How much assurance and confidence do you have that we are allowing people who are in school or or teachers or restaurant owners and so forth are truly going to be safe for themselves as well as safe for whomever they come in contact with. And we just don't have that information at this point. We're hoping that by so-called flattening the curves and sort of seeing the decrease in cases, that percentage of new cases, over the average go down, that maybe we'll be able to look at, at least phased in opening of key businesses, for instance. But I think the highest priority is always going to have to be with testing healthcare workers. I mean, and first responders. There's no question they're the ones at the highest risk. And until we can assure that they have the kinds of information, for instance, like infection status, as well as all the personal protective equipment and so forth, it's going to be really hard to say when we're going to open up schools. I've seen lots of projections that say, we really can't, even if we open them up in the fall, it's going to still look very, very different in terms of, the level of social distancing and, the scheduling and so forth, people going back to work. I mean, how can we ensure that people who work in very, very tight quarters, in offices, for instance, how are they going to be able to protect themselves unless they have information about, who has antibody, who's has immunity and so forth. So it's going to be really, really hard. But in terms of priority, I think it's got to be healthcare workers in all sorts of settings, whether it's hospitals, or primary care clinics where people are trying to, get help to figure out whether they have COVID or not, and nursing homes, jails, prisons, and so forth. I mean, those are the really high risk settings where we need to have that level of infection status information.
Okay, fantastic. And kind of on those same lines, as high school students, as some of us as seniors, we are kind of making our college decisions and wondering if you think college might be open in the fall semester or even next year. So from what you know, do you think that this might be a possibility and then that school next year, high school, college, will be online? And if so, how would that kind of affect education, or how do you see that affecting like the experiences and the education that students get?
Yeah, that's a really, really important question, I think, for you, as you're on that cusp of finishing and starting a whole new kind of career as an undergraduate, and I completely understand those concerns. I wish I had that crystal ball. Again, as I was just saying, I mean, a lot of it kind of depends on what kinds of information we're going to have about ongoing transmission and immunity. And of course, everyone's been at home. All the college students that have been in session for the first half of this year, they've all been sent home. What's going to be the impact of bringing them all back together again, whether it's in high school or whether it's in a new setting like college? In college, if you're living at college, you're in dormitories and so forth. So the risk of transmission, unless we have the tools, whether we have the tests, whether we have the treatment, whether we have the vaccine even, which is really, at least 12 to 18 months period away, I think it's going to be very, very hard to come up with a policy that works everywhere. It's going to have to be very, very specific to, where, which community, where people are coming from, where they're moving. I mean, just the whole issue of travel. Even when can we open up airports and allow people to travel from the United States to other countries and vice versa? I think, I wish I had that crystal ball. I wish I could see the trajectory of this infection with respect to all those other important components for control. We just don't have them in hand yet, but hopefully we will, and that will make a difference in terms of setting a timeline that makes much more sense, for you and for other students.
Right, definitely. And those are the major questions, and those are some really fantastic responses. And I'm sure I speak on behalf of everybody watching and everybody who benefit from this information to thank you for taking the time out of your day and kind of making this presentation, sharing it with us, kind of helping us learn more about epidemiology, about infectious diseases, and especially now where we're all directly infected, or not infected by it, but affected by it. It was really fantastic to learn really relevant information, and we could possibly use that to ourselves make small differences every day. And with that, I had one last parting question. So this is kind of a bigger picture. What do you think, or what are your recommendations, or what do you hope our generation does to kind of contribute and battle these bigger problems like the pandemic and like infectious diseases? What do you hope our generation can do to combat these and hopefully reduce or eliminate these problems?
I have a lot of optimism, absolutely. I think that your generation has really grown up in a culture of innovation and creativity, and you have the tools, I think, to really use them. And I mentioned the big science, the big data aspect of it. I think that you have a much better appreciation for how to use those tools to really solve a lot of these problems that have been barriers, I think, to really improving public health in general. And so I really love the idea, say, of community and crowdsourcing, for instance, that is so accepted. It's the norm, I think, for generation. It's this kind of openness to reach out and think outside the box. In my conversation with you and other students, that's something that really is very impressive to me, that we are really engaging people outside of our comfort zones. I mean, we're talking to people that probably we wouldn't have thought about talking to before, and that's true whichever discipline you are. I mean, I think that people go into medicine, realize they have to talk to the IT people, they have to talk to their congressmen, they have to talk to policymakers, and again, that takes a much broader understanding. And I think that we've learned a lot already about when we don't do that, that there's going to be real fragmented, ineffective solutions. And so I think, given your skill sets, everything I've seen, just even from that video, I think that kind of energy is really exciting to see. So I have nothing but optimism for what you're going to be doing going forward, and using that kind of holistic approach to everything.
Great. That's awesome. And that's about all the time we have. So one more time, I'd like to thank you, sincerely thank you, for having and hosting this and kind of being a panelist and sharing your thoughts and information. And for everybody watching, this is recorded, so I will edit this and then post it, so you can watch it again. Anybody else, you can share it with your friends or family, and you can gain this kind of information. And if anybody has any other questions, I'm sure you can ask it to me. You can email me, and then I could ask Ms. Chow, and hopefully you're open to answer a few more questions that might be coming later. But yeah, so that concludes the webinar, and I think this has been great.
Great, thank you. And I just have one more thing to say, and that is that everything I've said during this webinar and this recording is my own opinion. I'm not representing either the California Department of Public Health or CDC, and I just want to make that real clear. And I don't have any other industrial disclosures to make. Thank you.
Fantastic. Thank you, Ms. Chow, and thank you everybody for coming.
Okay, thanks so much again.
Thank you.
Bye.
Have a nice day.